Today, I will be discussing the management of insulinoma, and I intend to discuss this topic under the following headlines, following outline rather: background, epidemiology, clinical features, different diagnosis, investigation, treatment, prognosis, conclusion, and references. Insulinoma, as we know, are functional pancreatic islet cell tumors that was first described in 1927. They may present sporadically or may present as part of the multiple endocrine neoplasia type 1. Most insulinomas are benign. Averagely, about 90% of insulinomas are benign, whereas we have few of those that are malignant. Unlike we've seen in other causes, other types of neuroendocrine tumors, they tend to present mostly in the malignant pattern. The characteristic presentation of insulinomas include hypoglycemia, mostly fasting hypoglycemia in about 73% of patients, and about 6% of patients they do present with postprandial hypoglycemia, and in the remaining 27% or 21% they may present with mixed pattern, both preprandial and postprandial hypoglycemia. Talking about the epidemiology, insulinomas tend to occur in average of 1 to 4 in a million population, and the average incidence, average age of onset is around 50. That's at about the 50th decade. There's slight preponderance of females in about which shows female occurrence in about 53% of patients, and the remaining 47 being in males. 10% of insulinomas tend to present as part of the multiple endocrine neoplasia type 1. The clinical features, as I've said, are basically characteristically fasting hypoglycemia, and they may present with both adrenergic or neuroglycopenic symptoms. The neuroglycopenic symptoms, which include dizziness, confusion, convulsion, loss of consciousness, may be mistaken for a psychiatric illness, and some have been diagnosed as such. Weight gain has been seen in about 80% of such patients. And as we know, like in other causes of hypoglycemia, Whipple's triad must be demonstrated. Now, the differential diagnosis of insulinomas include familial hyperinsulinemia, which is otherwise known as persistent hyperinsulinemia, hyperinsulinemic hypoglycemia of infancy. There are other causes of non-insulinoma pancreatogenic hypoglycemia syndrome. They can also mimic postprandial hyperinsulinemic hypoglycemia, which is seen usually after gastrectomy. Hypoglycemia due to esophageal insulin, exogenous insulin therapy are also other possible differential diagnoses. Whereas also it can also mimic insulin autoimmune hypoglycemia. The investigations to diagnose insulinoma can be classified into those to establish diagnosis and those to localize the tumor. Usually, 72 hours fasting for those that present with mainly fasting hypoglycemia or mixed meal test are used. The latter is used for those that present with postprandial hypoglycemia. Now, the criteria include the position of blood glucose less or equal to 2.2, elevated C-peptide and insulin, and also low ketone like beta hydroxybutyric acid, and negative sulfonylurea screening test. Now, the localization can be done by imaging, which include transcranial ultrasound scan, spiral CT, MRI, and endoscopic ultrasonography, which is more of an invasive investigation, and also can be done using selective calcium stimulation tests, which can be used to diagnose insulinoma. The treatment of choice remains surgical removal, and other options include enucleation, medical treatment using diagnostic or octreotide. For follow-up, usually we do clinical assessment and tumor markers, and local assessment also can be done using imaging. The life expectancy is restored to normal after surgery, and insulinoma, in conclusion, insulinoma are rare tumors, and these are my references. Thank you very much.